Welcome to this explainer. Today we're taking all that dense anatomical data you've probably stared at for hours and turning it into a highly practical guide to hip musculature and manual muscle testing. If origin, insertion, and innervation tables usually make your eyes glaze over, well, you're in the right place. We're going to visually map out exactly how these muscles function and, more importantly, how you can accurately isolate and test them in a real clinical setting. Let's get into it.
Here is our agenda for this anatomical tour. We're going to cover the posterior thigh, anterior thigh, medial thigh, the TFL and sartorius, lateral rotators, and finally wrap things up with the gluteal muscles.
Section 1. Posterior thigh, focusing on the hamstrings.
So looking at this table, the crucial thing here is mapping out the origin, insertion, nerve, and action, or what we usually call ONA. Notice how the semitendinosus and semimembranosus anchor on the medial side, right? Meanwhile, the biceps femoris heads lateral. The biggest takeaway here? With the exception of the short head of the biceps femoris, these are two joint muscles. That makes them absolutely vital for both knee flexion and hip extension, and they're innervated primarily by the tibial branch of the sciatic nerve.
When it comes to manual muscle testing, you want to follow these precise steps to really isolate those hamstrings. Got your patient prone? Great. Now flex the knee to about 50 to 70 degrees. To bias the medial or lateral hamstrings, you simply rotate the thigh to match. But here's the kicker. Pay really close attention to step 4. You need to apply pressure against the lower leg in the direction of knee extension, but you have to be incredibly careful not to apply pressure against the rotation component itself, just pure extension.
Now, why does all this matter? Recognizing these clinical signs of weakness, or shortness, is absolutely essential because they drastically alter knee stability and pelvic alignment during weight bearing. For instance, if you have bilateral weakness, you'll almost always see knee hyperextension and an anterior pelvic tilt. It's wild. If you isolate a lateral hamstring weakness, you're going to observe a loss of lateral knee stability, which gives you that classic bow leg thrust. Oh, and a quick clinical pro for you. If your patient starts cramping frequently during this test, it just means the muscle is in way too short of a position while they're trying to hold against your pressure.
Moving right along to Section 2, anterior thigh, looking at the quads and iliopsoas.
It is honestly fascinating how distinctly segmented the roles are within this anterior group. Look at the vastus group. Lateralis, intermedius, and medialis, they all originate right on the femur and are strictly dedicated to extending the knee, no hip involvement whatsoever. However, look at the rectus femoris. It originates all the way up on the anterior-inferior iliac spine, meaning it crosses both the hip and the knee. And similarly, you've got the powerful iliopsoas group crossing from the lumbar spine and pelvis straight down to the lesser trochanter, which makes them your dedicated hip flexors.
Okay, testing the quadriceps. You're going to have the patient seated with their knees dangling over the table. You ask for full extension of the knee joint. Make sure there's zero thigh rotation, and you apply pressure downwards, towards flexion. But here is where you really have to keep your eyes peeled. Watch to make sure the patient doesn't lean backward. If their rectus femoris is their strongest quad muscle, they are going to instinctively lean back to extend the hip. It's a classic cheat to put that two-joint muscle at a better mechanical advantage. Testing the iliopsoas is a completely different ballgame. The patient lies supine. To get an accurate read on this muscle, you absolutely must stabilize the opposite pelvic crest to stop any anterior tilting. Then, you bring the hip into full flexion with just a slight bit of abduction and lateral rotation. When you apply your pressure, you're pushing directly against the anteromedial leg towards extension. Basically, you're directly opposing that specific line of pull from the lumbar spine straight down to the femur.
Section 3. Medial thigh, focusing on the adductors.
When we look at the adductors, so the pectineus, adductor magnus, gracilis, and the brevis and longus, notice how diverse their actions actually are. Beyond simply bringing the leg inward, adduction, many of these muscles actively assist in hip flexion. In fact, if you look at the posterior fibers of the adductor magnus, they even assist in hip extension. So they aren't just one-trick ponies, they are highly dynamic stabilizers. To test this group, the sideline position is your best friend because it beautifully isolates adduction against gravity. You just hold the upper leg out of the way and have the patient lift the underneath leg straight up from the table. But again, you got to be vigilant here. If you see the patient anteriorly tilting their pelvis or rolling backward, that's a massive red flag. It signals that their hip flexors are stepping in and trying to take over for weak adductors. Now, this next point highlights a profound mechanical reality, and it actually settles a lot of academic debate over whether adductors are medial or lateral rotators.
Look at the difference between the anatomical axis of the femur, which as you can see is curved, and the straight mechanical axis running right from the center of the hip down to the center of the knee. The rotation action of an adductor depends entirely on whether its insertion on the femur sits anterior or posterior to that straight mechanical axis during a specific movement. It's a total light bulb moment for functional anatomy, right?
All right, Section 4, TFL and sartorius.
Let's look at two highly specialized multi-joint muscles side by side, the tensor fasciae latae or TFL and the sartorius. Even though both of these muscles originate way up near the anterior superior iliac spine, and they both flex and abduct the hip, look closely at their rotation actions. They are exact opposites. The TFL pulls into medial rotation while the sartorius pulls into lateral rotation. This means distinguishing between them during testing is purely a matter of rotational physics.
Because of these combined actions, a really common clinical error is confusing a resting adductor posture with a true sartorius test. Just letting the leg kind of rest there in a flexed and abducted position requires almost zero sartorius effort. To get a valid test, you need active, forceful resistance against the specific rotational and abduction components at the exact same time. It's active, not passive.
When you're testing the TFL, you place the patient supine, and it is absolutely imperative to keep the knee fully extended here. You ask for hip abduction, flexion, and medial rotation. If that muscle is weak, you are going to immediately see the patient fail to hold that medial rotation. Fun fact, in a standing posture, TFL weakness often presents as a bow leg thrust, specifically because of its strong connection to the iliotibial tract.
Moving on to Section 5, lateral rotators. Now we are journeying deep into the hip structure to examine the lateral rotators. This is a dense cluster of 6 deep muscles. You've got the piriformis, quadratus femoris, the 2 obturators, and the 2 gemelli. As you can see, they originate all across the sacrum, ischium, and obturator membranes, but they all converge on or near the greater trochanter. Despite their different origins, they share one primary common goal: forcefully laterally rotating the hip joint.
To test them, sit the patient with their knees bent over the table. You ask them to literally rotate the thigh, which, counterintuitively, actually means swinging their lower leg inward across their body. By having the patient seated and pushing their lower leg outward against their effort, we are effectively challenging this entire cluster's ability to resist medial rotation.
And finally, Section 6, the gluteal muscles.
Here we are at the primary powerhouses of hip and pelvic stabilization. Breaking down the gluteal group, we see some very clear functional divisions. The gluteus medius and minimus, which are innervated by the superior gluteal nerve, are your critical abductors and medial rotators. Conversely, the massive gluteus maximus, running off the inferior gluteal nerve, is the primary driver for powerful hip extension and lateral rotation.
Now, testing the gluteus medius is notoriously tricky. You've got to watch the pelvis like a hawk during a sideline abduction test. If you see any pelvic hiking, dropping, or backward rotation, that means the trunk muscles, or the TFL, are stepping in to substitute for weak abductors. True weakness here completely alters how a person bears weight. They end up shifting their center of gravity laterally over the stance leg just to stay upright and balanced.
In severe cases of gluteus medius weakness, this failure of stabilization results in the classic Trendelenburg sign. This is a devastating drop of the pelvis on the unsupported swing side. To keep from literally falling over, the patient is forced to lurch their trunk over the weak stance leg, which creates this highly inefficient compensatory waddling gait.
Which leaves us with a final fascinating question to ponder. Considering how intricately all these muscles overlap, sharing origins, trading off rotational duties across mechanical axes, constantly balancing each other, how does one single, isolated weakness cascade through the entire kinetic chain? The next time you analyze human movement, remember these intricate tables and tests. Every single step we take requires an absolute masterpiece of muscular orchestration. Thanks for joining me on this explainer. Keep learning, and I'll see you next time.